next plenary session.
I want to, especially on behalf of Sogon, to thank the OK Organ lecturer for this wonderful rendition. You know that OK Organ came before his time. For him to have formed Sogon in 1965, if not for him, maybe we wouldn't be here today. I understand he was the first Nigerian to be a gynecologist, and he rallied others to form this society and became the first president. So there's nothing we can do to finally thank him. We must be thanking him. And for this, council had very strong deliberation before, because it's our job to choose somebody who will do the job very well. And you can see that our selection was excellent. So Professor Deem has done a very good job. And so we normally select, it's not by gra-gra. We think and think and think and hold many meetings, and we say this man is going to give this lecture. So next year lecture, we shall move on to another person that we shall also commemorate. So that time again, council will think and appoint a suitable person. So on that, I want to thank everybody for coming and for listening. All the things we are told to do, remember it is at 20,000 per person that we shall use to eliminate this cervical cancer. So you help us to advocate to government. The federal government has a national task force for elimination of cervical cancer, of which you know very well that you're a member. And the Sogon president is chair of one of the committees. So Sogon is not quiet. And we recommended many Sogon members who are working on that task force. So thank you very much.
Yes, taking it. Yes. Thank you very much. So we'll quickly move to the next session, which is strategies for prevention of gynecological cancers. And we're going to take it for just one, Professor Chibu, who is going to be our presenter. Please, can you please join us on stage? The chairman is supposed to be Professor as to something urgent. Take care of this. So my immediate past second president, please can you join us here? Please clap for him. And our co-chair is Professor Oyuje Umwera. I don't know if he's around. He has stepped out. So I don't know if Professor Oliver Ozechi can do emergency co-chair. Professor Ozechi, please. Apologies for not informing you earlier. Our rapporteur is Dr. A. Jackson. Is he or she here? Please join on stage. My chairman, sir. 20 minutes.
Yeah, thank you very much. Since the focus this morning is on cancer prevention, and we have now honed in, we did with a major lecture, we did cervical cancer. But now, since that's not the only cancer that's bedeviling us, and we've been told yesterday that our interest has been majorly focused on obstetrics, and that we cannot but look at what is really plaguing our population. So, Chiefs is going to be giving us this lecture on strategies for prevention of gynecological cancers. Please proceed.
Thank you so much, Mr. Chairman. First of all, let me thank the President of Sogon, the LOC, and the Chairman of the Scientific Committee for inviting me to make this presentation. So I would say that my presentation is a smaller and bigger presentation. At the same time, smaller in the sense that we can't fit into the footsteps of Professor Organ, having heard what Dim said about him. Bigger in the sense that we're expanding beyond cervical cancer. So I'm going to talk about all gynecological cancers combined. So Professor Dim has made my work a lot easier. He has taken the cervical cancer component. So I will only skip through a few of them and then go down on the other side. Because cervical cancer actually is the cancer that has the most potential for elimination. So he has said so much on that, and I'll proceed from where he stopped. So I don't want to go too much on the statistics. He has given us a lot about that. So, but I need for us to take a look at the statistics in front of you, that we have these statistics on gynecological cancers as a whole, not just cervical cancer. So we talk about the deaths per year above 600,000 globally. The new cases, about 1.4 million, and the 5-year prevalence, 4.6 million. That's for all gynecological cancers, and that's quite huge. Then I'll go on to talk about the Nigerian statistics. So the deaths per year for all gynecological cancers is 10,000, a little bit above 10,000. The new cases, we have about 19,000. We have 41,000. Again, it made it clear to us that these actually tip of the iceberg, because these are projections. These are mathematical modelings that were used to give us these figures, because we don't have cancer registries. But there's something I really want to look at, which is very interesting here, is the incidence versus mortality. So you see, cervical cancer has this big incidence, always there, it's always the elephant in the room, both globally and in Nigeria. But this is the global data here. But when we look at the mortality, we will see that it's about 53% mortality that we have annually. But then you look at ovarian cancer there, we're dealing with about 64% mortality. So ovarian cancer is actually very deadly, much more deadly than any of the other cancers, as much as it's not as prevalent as cervical cancer. So data. The same thing goes with the Nigerian data too. So we have the same thing here, about 52% mortality for cervical cancer, and then we have also about 64%. So we are mirroring the global data. For the, I don't know whether it's because of the mathematical modeling, but I think that if we really get our data, we're really going to get something much more than what we have. So, Dim has said a lot about this, so I don't want to go dwelling on this a lot. He has talked about how to rally people around for us to prevent gynecological cancers. So I try to, in this slide, talk about the critical stakeholder. But he has done that, but I want to say that the government plays a big role in rallying every other stakeholder in this journey. So what are the preventable cancers? So looking at it, collectively, 50 to 60% of gynecological cancers are preventable, 50 to 60%. So we could say that roughly more than half of gynecological cancers can be prevented. And we try to categorize them into highly preventable, moderately preventable. Cervical cancer, highly preventable, almost all could be prevented. Endometrial cancer, 30 to 40%. Vulvar cancer, 40 to 50%. Ovarian cancer, 10 to 20%. And I'm sure some of us may marvel that we have these statistics about the preventability of gynecological cancers. And so why are we having the huge statistics of mortality and incidence? So looking at the three-level population disease prevention, we always teach our students that primary prevention has to be when there's no disease, you prevent. Secondary prevention, when there's subclinical disease or precursor disease, you detect and treat. And tertiary prevention has to do when you diagnose disease, you treat. One of my students asked me, why did we say important that we must incorporate that into our prevention strategy? So for primary prevention, I would start with cervical cancer. Dim has said everything here, so I'm going to run through these slides on cervical cancer. I'll run through them. Here, maybe what I need to say here in this particular slide is that we have about 3 months, the cytology test and the visual inspection. So I will still run through this. Dim said a lot about this, so that I could meet with the 20 minutes mark. So, but what next when we screen positive? So what do we do with cervical cancer? We can either screen and treat, he mentioned it, triage, he mentioned it. We can also screen, confirm, and treat, which is what is done in developed countries. So about the triaging, what do we triage with? We can triage with partial genotyping. So if you have a woman screening positive for HPV, high-risk HPV prototypes, you can decide to say, check again on whether you have 16 and 18, and that will be your triaging. And you could also do the dual staining technique. We are looking for some proteins there, which are markers for effectivity. You could also do colposcopy. You could also pap smear or VIA. All these are acceptable by WHO, although it's undergoing revision at this moment. So when you have the triage cases that are positive, you just treat if you are triaging. If they are negative and the patient is HIV negative, you do it again in 2 years. But if it's HIV positive, you do it in 1 year. That's very important. So Dim also said a lot about the WHO strategy. Incidentally, I didn't know the topic was going to present, so I put everything together here. So, but I will move forward. What about the Nigerian response? He also said something about the Nigerian response, but I'll mention one thing he didn't mention, that there is the National Strategic Plan for Prevention and Control of Cervical Cancer that will be ending at 2027. So between 2023 and 2027, they have a big plan. They want to decrease the burden of cervical cancer by 1/3 of what it was at 2021 by 2027. And they looked at immunizing 50% of girls 9 to 14 with HPV by 2027. Already they are meeting that mark. Something we should be proud of, something we should actually be clapping for, because they did this within 2 years of starting off the immunization program. Whether the data is correct or not is something we have to look at, but they're already there, they've passed that mark. They want to screen women, 50% of women between 25 and 49 years of age, at least twice by 2027, and treat 100% of precancerous lesions by 2027. These are tall orders. These are where we have problems. So, again, Dim also told us about the response, which led to vaccination of 12 million girls in 2 years, and that's quite a record. So what haven't we gotten right so far? Why are we lagging despite this monumental achievement on vaccination? We have not gotten right with mass public education needed to mobilize the public. Again, we have not coordinated effort at massive screening, not mass screening, not the screening campaigns we go from village to village. Massive screening that has to be coordinated across the 3 levels of healthcare. We have also not done the massive capacity building that we need to train the manpower that will treat the detected lesions. I was in the colposcopy training pre-conference workshop, and I could see the huge gap we have in terms of manpower to treat the detected precancers. HPV testing is not available in the majority of our health institutions. That's another funny thing. We don't have it. And there is no widespread availability of ablative treatment methods in the country. So I did a survey some time ago, and I sent it to most institutions to tell me if they have HPV screening, if they do HPV screening tests in their institution. I also wanted to know what treatment modalities they use. A lot wrote, we don't. So, thank you. So that's the problem. So that's what we've not gotten right. So I'll quickly move to ovarian cancer. Unfortunately, once you leave cervical cancer, move to any other cancer, gynecological cancer, you have a problem with mass screening, population screening, the general population screening. We don't have that. So what we do is that we try to prevent the ones we can prevent. So what is recommended is that you don't screen everybody. You screen just individuals at risk of inherited ovarian cancers, because screening has been found for general population, has not been found to be beneficial, unfortunately. So who are these people that are at risk? These are women with family history of BRCA1 and BRCA2 mutations. These are women with Lynch syndrome, family history, and family history of ovarian, breast, tubal, and peritoneal cancers. These are the women at risk, and these are the women that should be screened, not the general population. We are not expected to ask women to come for ovarian cancer, everybody come, the way we ask them to come in cervical cancer. No. Only those who have these problems, who have this history should come. So why do we do this? Because BRCA1 and BRCA mutations increase the risk of ovarian cancer. You can see the figures on the screen there. And that we also need to screen for LH, RAD51C and RAD51D genes, and other genes in the panel test. There's so many genes developed in the panel testing. But if we can only do the three highlighted before the other genes, then we are good to go. So what do we do after we have screened them and they are positive for inherited ovarian cancer? So the first thing we can do is to do what we call risk-reducing bilateral salpingo-oophorectomy for those patients. And the other one will be for us to do what we call risk-reducing bilateral self-injectomy. Almost the same thing, just that in one of them you are not taking out the ovaries, and the other one you are taking out just the tube. So when do we do that? The timing, ideally at 35 to 40 years of age, when they've completed their family size. Or if there's history in that particular individual shows that ovarian cancer was diagnosed early in that family, you do it earlier. Again, very important in the light of the current knowledge that we know that most ovarian cancers actually arise from the tube. We are beginning to let gynecologists inform the pathologists to do adequate processing of the tubes whenever we remove this, because it's very important. So for endometrial cancer, we still don't have a recommended general screening method for everybody. And the reason is that it has early presentation and has high rate of detection when it presents early. And so it's unlikely that a general population screening will be of any impact. So whom do we screen again? Again, we look at those women that carry the LH2 risk. Those women carry a 60%. If you have a LH2 gene, you have 60% risk of endometrial cancer. So we screen for those people and their first-degree relatives who had endometrial cancer before the age of 60. Importance of history here. And first-degree relatives of women who had colorectal cancer before 60 years of age. We all know what that means in terms of the LH2 syndrome. You know, the breast cancer, ovarian cancer, colorectal cancer syndrome. Very important. So what next? What do we do when we have screened positive for those? We do annual transvaginal ultrasound from age of 35. That's where it works. It doesn't work in the general population. If we do it for this population of people, then we are likely going to get some important headway. Then endometrial sampling can be done 1 to 2 years, beginning at the age of 30 to 35. Prophylactic hysterectomy and bilateral salpingo-oophorectomy in early to mid 40s, after childbearing, of course. And of course, colonoscopy, don't forget, 1 to 2 years, but you have to begin at an earlier age, 20 to 25. So that's what we do for this group of people. So for ovarian cancer, it's also preventable. As much as 50% of ovarian cancer, depending on the series we are looking at, is associated with HPV. So you have the chronic high-risk HPV must incorporate efficient primary, secondary, and tertiary prevention. The strategies must